All right, let's dive into managing infections in cancer patients. This is a really complex topic, but honestly, mastering it is so critical for your PEBC exam because it really tests how well you can connect all the dots, the patient, the bug, and the right drug.
So here's our game plan. We're going to walk through this just like you would in a real clinical setting. We'll start with the basics, then move through the patient workup, non-drug options, the nitty-gritty of pharmacotherapy, and then wrap up with how to prevent these infections in the first place. Let's jump right in.
Okay, first things first. Before we can even think about treatment, we have to be on the same page about what we're trying to achieve and the key definitions that are going to guide every single decision we make. And the big takeaway here is that our goals are about so much more than just, killing the bug. We are trying to reduce harm from the infection, boost the patient's quality of life, and think ahead to prevent future problems, all while being smart about antibiotic use and keeping patients out of the hospital if we safely can.
Every single investigation is going to start with a trigger. And in this world, that trigger is fever. Now, the definition is super specific, and you absolutely need to know this for your exam. It's a single temperature of 38.3 degrees Celsius or higher, or a sustained temp of at least 38 degrees for an hour. You gotta have those numbers down cold.
And this right here, this is the absolute core risk factor, neutropenia. The magic number is a neutrophil count of 0.5 times 10 to the ninth per liter or less. But here's the really critical part, profound neutropenia, which is less than 0.1. I mean, that just sends the risk of a bad infection through the roof. These are hard numbers you just have to memorize.
Okay, so we've got our definitions locked in. The next logical question is, what's our game plan when a patient actually shows up with a fever? How do we investigate? This flowchart, this is your mental map for that initial workup. You can see how it all flows. You confirm the fever, you dig into their history and do a physical exam, and then you hit that first big decision point. Is this patient neutropenic?
The investigation itself has to be really systematic. The history gives us vital clues about when they got chemo and what their immune system is like. The physical exam is basically a head-to-toe hunt for the source of the infection, paying super close attention to high-risk spots like IV lines. And then, of course, the labs and imaging give us the hard data we need.
Now, before we even start talking about drugs, we have to cover the non-pharmacologic stuff. You can think of these as building a protective bubble around the patient.
Think of these as layers of defense, right? It all starts with the absolute non-negotiable basic, hand washing. Then, for our highest risk patients, the ones who are profoundly neutropenic, we step it up to things like special air filters. And of course, we use specific precautions for known bugs, and we do simple things like keeping fresh flowers out of the room, since they can carry fungal spores.
All right, let's get to the main event, the part that's going to be all over your PBC exam, the drugs. We'll kick things off with that classic scenario, the febrile neutropenic patient.
This algorithm right here is your Bible for managing febrile neutropenia. Seriously, spend some time with it. It takes you all the way from that initial risk assessment to choosing drugs and knowing when to add antifungals. So let's break this thing down piece by piece. So that very first decision you have to make right at the top of the algorithm is where are we going to treat this patient? And it's not a guess. It's based on a formal risk assessment. So what exactly goes into that crucial choice?
This is basically the checklist we run through to find our low-risk patients. You ask, is the neutropenia going to be short? Is the patient otherwise stable? Is their cancer under control? If you can say yes to all of that, then maybe, just maybe, they can be managed as an outpatient. If not, they're getting admitted. Okay, so for most of our inpatients who don't have those really scary high-risk features, we start with one powerful antibiotic. The foundation is a broad-spectrum beta-lactam that kills Pseudomonas. Piptazo is a total workhorse. Cefepime is another great choice. The carbapenems, like meropenem, are kind of our big guns that we try to save for sicker patients to avoid resistance. And just remember that little pearl about imipenem and seizure risk, especially if kidney function is poor.
Next up, vancomycin. A huge principle of good antibiotic stewardship is that we do not just throw vanc at every single patient. No way. There are very specific red flags that tell you to add that gram-positive coverage right from the get-go.
And here they are. You pull the trigger on vancomycin if the patient's blood pressure is tanking, if you're pretty sure their central line is infected, if they have terrible mouth sores, if you already know they're an MRSA carrier, or, well, if the lab calls and says they're growing gram-positives in the blood. If none of those are present, you keep it in your back pocket.
Now, what if vanc isn't the right choice, or you're up against VRE? Well, these are your go-to options. The key is knowing what makes them different. Linezolid is great because it has an oral form, but you have to watch for low platelets and that really dangerous interaction with SSRIs. Daptomycin is awesome, but you gotta monitor for muscle damage. And this is a classic exam question, you can never use it for pneumonia. Why? Because the stuff in our lungs literally deactivates. Okay, so you've done everything right. You've got them on good, broad-spectrum antibiotics. But it's been 4, 5, 6 days, and they're still spiking a fever, and their neutrophil count is still in the basement. This is a huge pivot point. So what does that persistent fever tell you?
And there it is. A persistent fever for 4 to 7 days despite good antibacterial coverage. That is your classic trigger to start thinking about fungus. At this point, you have to work under the assumption that an invasive fungal infection is the real bad guy here.
When we talk about invasive fungal infections in these patients, the first thing that should pop into your head is aspergillus. And for aspergillosis, voriconazole is the top choice, because studies have shown it works better. Just remember its famous side effect, those weird temporary visual changes. Isavuconazole is a newer player that works just as well with a friendlier side effect profile. And good old amphotericin B is still a key backup.
And this is a perfect exam-style clinical pearl. It's not enough to just pick the right drug, you gotta pick the right formulation. See, the IV version of voriconazole has this delivery vehicle, cyclodextrin, that can build up if the kidneys aren't working well. So for any patient with a creatinine clearance under 50, you should probably go with the oral form.
Now, when it comes to viruses, we completely flip the script. Unlike with bacteria and fungi, we do not use empiric antiviral therapy. Treatment is always targeted. You only treat if you have solid evidence. If you know it's the flu, you use something like oseltamivir. If it's herpes, you use acyclovir. If it's CMV, you use ganciclovir. It's all about treating a specific confirmed virus.
So we spent a lot of time on treating active infections, but honestly, an even better approach is to stop them from ever starting. And that's where prophylaxis comes in for our most vulnerable patients.
This table is a fantastic summary. For patients who we expect to have deep, long-lasting neutropenia, think acute leukemia patients, we'll use an antibacterial like levofloxacin to prevent infections. For antifungal prophylaxis in that same group, posaconazole is the star for preventing molds like aspergillus. Acyclovir was pretty standard to stop herpes viruses from reactivating, and for anyone with a major T-cell defect, you have to protect them against PJP, usually with trimethoprim sulfamethoxazole.
Another key way we can support these patients is by using drugs to shorten that window of danger. Colony-stimulating factors, or GCSF, they don't fight bugs themselves, but they're like a boot camp for the bone marrow, helping it pump out new neutrophils much faster.
We use GCSF in a couple of main ways. First, as primary prevention for chemo regimens that we know have a high risk, we're talking over 20%, of causing febrile neutropenia. And second, as an extra bit of help for patients who are already sick with an infection and are profoundly neutropenic. Now here's a really important point to remember. While GCSF definitely shortens the neutropenia, it hasn't been shown to actually improve mortality.
All right, let's wrap up with long-term prevention, and that means talking about vaccines. This is such a critical piece of the puzzle because for vaccines to be both safe and effective in these patients, timing is absolutely everything.
Here is the first number you need to burn into your brain. 4 weeks. Live vaccines are a huge no-no during immunosuppression. They are completely contraindicated. So they have to be given at least 4 weeks before the immunosuppressive therapy begins.
And here's the second key rule for timing. 2 weeks. For all the inactivated vaccines, like your standard flu shot, you want to get those in at least 2 weeks before starting therapy. That gives the immune system a fighting chance to actually build a response.
But, and this is a really important but, even if you get the timing perfect, you have to remember that the patient's underlying disease and their treatment can still weaken their immune response. So the protection they get from that vaccine just might not be as strong or last as long as it would in a healthy person.
Okay, to bring this all home, let's put what we've learned into practice with a classic clinical case. You've got a super high-risk patient with AML, they're profoundly neutropenic, they have a confirmed mold infection, and their kidneys aren't working well. So based on everything we just covered, the preferred drugs, their side effects, those tricky formulation issues, what is the most appropriate initial therapy? Really think it through. This is exactly the kind of problem solving you'll need to do, not just for your exam, but in real life.